keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, this is Christopher Kramer from the University of Virginia on behalf of JACC, Cardiovascular Imaging, and with me today is Dr. Frank Bogan from the University of Michigan, and we're here to discuss his interesting paper that is being published in JACC Imaging regarding imaging of ablation lesions after ablation of ventricular tachycardia with cardiac magnetic resonance imaging. Dr. Bogan, can you tell me what prompted you to do this study?
Well, we do routine MRIs in patients who undergo mapping and ablation procedures for ventricular arrhythmias, and we noticed that in MRIs that we do after a procedure to see whether there's any interval development in the findings of the initial MRI, that there were lesions that were most likely attributable to the ablation procedure that we did in the area where we found these lesions. So we looked closer at that. We usually do MRIs before the ablation procedure, and if there's no structural abnormalities, we usually repeat another cardiac MRI a year to 2 years after the initial MRI if it was unremarkable, to see whether there's any interval development that we didn't see before.
How many patients did you include in this particular study?
These were 35 patients without structural heart disease that we included.
And can you describe some of the lesions that you imaged at 2 years, I believe, right?
Yes, at 2 years. It depends, obviously, where we did the mapping and ablation procedures. The majority of the patients had ventricular arrhythmias. Frequent PVCs was the predominant arrhythmias, or ventricular tachycardia, originating from the right ventricular outflow tract. We had other patients who had epicardial ventricular arrhythmias, and we would see the lesions in the epicardium, obviously. The most interesting lesions we saw and surprising lesions that we saw were when arrhythmias from the papillary muscle were targeted. Interestingly, in these are very difficult arrhythmias to take care of, because catheter stability is one of the big problems that we have to face during the mapping and ablation procedure. And very often when we ablate, the catheter slides off the papillary muscle and falls onto the back wall of the on the surrounding wall of the heart. And not surprisingly, because of that, we found the majority of the lesion to be on the wall surrounding the papillary muscle rather than on top of the papillary muscle. That probably explains also why we, in this series, did not have any evidence of papillary muscle dysfunction, because the bulk of lesion actually went away from the papillary muscle. It's kind of collateral damage that we caused by the ablation lesion.
There were a subset of patients in which you weren't able to image any ablation lesion at 2 years. Can you tell us about those patients?
Yeah, those were predominantly patients who had arrhythmias from the right ventricular outflow tract. And it's possible that because we didn't actually set up the protocol to image lesions from the right ventricle, we set up the inversion, we maximized inversion times for the nulling of left ventricular MR signals, and by that might have missed some arrhythmias originally, some of the lesions that we delivered in the right ventricular outflow tract.
And I understand you found a relationship between the energy applied and the size of the lesion. Is that correct?
Yeah, that's correct. The longer the ablation was, the larger the lesion in the endocardial surface area, as well as in the total lesion volume. Interestingly, we did not find that lesions were larger when we used irrigated tip catheters, but that may have something to do with the way how we titrated the power of the irrigated tip catheter.
Well, thanks for coming to discuss your very interesting paper with us, and look forward to reading it in JACC Imaging.